disclosures are that I'm president of Miyazaki Enterprises. I'm a contract instructor, speaker for American Medical Systems. I would like to give special thanks to Drs. Mikio Nihira and Colonel Ernest Lockrow for sponsoring me as a member candidate. This video is dedicated to Dr. Fred Miyazaki, a previous member of the SGS, whose contributions include saline amnion infusion for repetitive deep variables, the Miya hook for sacrospinous ligament suspension, and for instilling in me the art of teaching. Vaginal hysterectomy is still the preferred route, and there is substantial literature supporting its lower complication rate and cost. However, the route of choice is being taught less and less in our residency programs. And in a study on assessing current trends in resident hysterectomy training by Burkett and colleagues, only 38.1% of program directors and 27.8% of residents reported graduating residents as being completely prepared to perform a vaginal hysterectomy on their own. This problem has led to the Milestone Project, which is designed to provide outcomes-based accreditation. The intent of the project to reassure the public that physicians entering clinical practice have demonstrated the educational outcomes and proved their proficiency in all dimensions of the domains of clinical competency required to graduate from an accredited program. But with low case numbers and no standardized vaginal hysterectomy simulator, how can this happen? Welcome. You are seeing the first multi-procedure vaginal surgery simulation training model. It features a lifelike skin texture and highlights all the important surgical anatomic landmarks essential for vaginal surgery. This innovative simulator enables a student to actually perform basic gynecologic procedures such as bimanual exam, pap smear, IUD insertion, hysteroscopy, dilation and curettage, and advanced surgeries like retropubic and transobturator midurethral slings, sacrospinous ligament suspension, and vaginal hysterectomy. The Miya model is designed to simulate the entire vaginal hysterectomy procedure. An exam is performed first to assess uterine size and mobility, and the anterior and posterior cul-de-sacs are palpated. The vaginal mucosa over the posterior cul-de-sac is tented and incised with sharp dissection. The scissor tips are kept in a perpendicular orientation to the uterocervical axis. The bladder is sharply dissected free and protected. The scissor tips are kept in a parallel orientation to the uterocervical axis, and the peritoneum is centered sharply. Traction on the cervix helps with proper clamp placement around the entire uterosacral ligament. Cutting against the clamp decreases tissue necrosis. A Haney stitch is shown here, and this is tagged for use with the vaginal cuff closure or McCall's caldoplasty. It is important for the clamp to slide off the uterus and stay inside the uterosacral pedicle. Assistants can be shown how to maneuver the clamp for proper knot placement at the heel of the clamp to ensure there is no soft tissue between the clamp and uterosacral pedicle. If the pedicle is not tied well, the vascular system will bleed. The ureters can be palpated at 2 and 10 o'clock against a curved diva retractor and are protected with traction on the cervix and retraction of the bladder with the diva. Different uterine morcellation techniques can be practiced, such as bivalve and wedge resection. Seen here is the walking technique for delivering the larger uterine fundus. Keep in mind, uterine morcellation should only be done after entry into the anterior and posterior pelvic cavity has been accomplished and the vascular pedicle is secured. As shown here, the fundus can only be popped out after complete ligation and transection of the upper pedicles. For larger pedicles or in anticipation of removing the ovaries, the round ligament may be taken as a separate bite. The uterovarian ligament is clamped across, and as you can see, the open-ended torso has a distinct teaching advantage for difficult clamp placement. A tie on a right angle clamp is shown here. Other options are endoloops and vessel sealing devices. A modified McCall's cultoplasty is demonstrated. The suture first goes through the vaginal mucosa. It incorporates both uterosacral ligaments and posterior peritoneum, and then exits back through the vaginal mucosa. The uterosacral ligaments should be incorporated into the vaginal cuff closure, and full thickness bites, including the posterior peritoneum, are recommended. The corners are sutured in a figure of 8 fashion, and the remaining vaginal wall closed with the running lock or figure of 8 stitches of absorbable suture. The Miya model provides a realistic surgical experience not available until now. Surgeons can practice, build their muscle memory, increase their skill and confidence without any risk to our patients. The anatomy is constant, so it can be used as an objective standard for assessing skill and competency. The ACOG Simulation Consortium has developed a vaginal hysterectomy assessment tool, and each of the clinical performance tasks can be measured with the Miya Model Vaginal Surgery Simulator. Thank you for the honor of showing this video.